So I think we're going to get started. And I'm Carolyn from iLabs. I'm very excited to introduce our speaker tonight. We have Dr. Jaquel Patterson. She is a nationally recognized naturopathic physician, a highly sought after speaker, success coach, three-time Amazon bestselling author, most notably Women in Lyme, and Forbes contributor. She is the founder of Fairfield Family Health based in Fairfield, Connecticut, a successful multi-disciplinary integrative medical practice, and has over 16 years of clinical experience. With particular expertise in Lyme disease and chronic infections, integrative psychiatry, women's health, and environmental medicine. She has trained thousands of practitioners over the years in functional medicine, providing clinical pearls and application into practice operations. Please welcome Dr. Jaquel Patterson.
Okay, thank you so much. Thank you everyone for being here. We'll just give a second. Okay, we're at 8:02. So as she said, I am Dr. Jaquel Patterson, really looking forward to presenting today on behalf of iLabs. And just so you guys know, we have the chat box there on the bottom, and then we have Q&A. So for the purposes of the discussion, if you guys have questions for like transcript, and I know you guys will have access to the recordings for people that were able to come in, live or not. But if you put the questions in the Q&A, we can be prompting that way. If folks want to unmic and ask questions, we can, but definitely prefer in Q&A so that the questions can be like transcribed. Okay, so I always like to see where everybody is coming from. I'm here in Connecticut, so it's 8 o'clock Eastern Standard Time here, but it's always interesting to see where folks are coming in from, so feel free to put that in the chat. Okay, so let's get started. Okay, you guys can see this, Carrie? I just want to make sure before we begin.
Yep, you're good.
Confirm. Okay, great. So today we're going to be presenting on the advantages of using T-cell diagnostic testing for long haul COVID. And what we're going to be doing is highlighting the T-cell technology, particularly for iLab. So who am I? She already explained who I am. Licensed naturopathic physician, have been practicing 16 years now, based outside of Connecticut, see patients though throughout the country, particularly for Lyme disease, integrative psychiatry, and then also for environmental medicine. It's usually areas of chronic complex disease conditions. Early on when COVID, happened in about November 2020, I got COVID myself. And one of the things that we did at that time, based on our experience, we saw a lot of reactivation. We're going to talk about that later with the case studies of infections like EBV, Lyme disease, going from even IgG to IgM. And so because of that and that experience, we, both myself and my colleague, Dr. Medea, came out with a book called Long COVID and Beyond to discuss like the types of testing in terms of reactivation of infection. So it's interesting to, full circle, talk about that as we go through some of the case studies later on in the presentation. Okay, so what will we be reviewing today? So we're going to go through three objectives, and that's going to be first understanding immune function, both going through adaptive and innate immunity. Then we're going to go through a review of T-cell testing and benefits. And then we're going to go through clinical application review of the T-cell diagnostic testing for long COVID, haul COVID. And as I mentioned, we are going to have an open about 10 to 15 minutes at the end for Q&A. I will also have Felix Schultz from iLabs on as well. So any particular questions regarding the testing, we will be sure to have time at the end to answer any of those questions. Okay, so before we go into the test itself and the T-cell testing and why this is uniquely different, it's important to just go through a broad overview of immunology and the immune function. So we have both our innate immune function and we have our adaptive immune system. And so the innate immune system, that's going to be more of the immediate response that you're going to have where, as you see in this picture here, you have these pathogens immune cells engulf and kill the pathogens and release molecules to enhance the immune response. And the adaptive immune system, you have both the B cells and T cells, but the difference is there's going to be more specificity. For there's going to be more specificity. So the B cells make antibodies that target specific pathogens, and then the T cells kill pathogens and attack infected cells. And then some of these T and B cells will become memory cells to quickly fight the infections when they present themselves again. So the biggest things, the immune system has a need to identify pathogens. So pathogens have antigens on their surface that has provides this unique signature to recognize different pathogens. So we will discuss that as well. So they have this unique signature to identify the pathogens. And again, we have the innate immune response, which is more of a rapid response. That's going to include things like natural killer cells, interferons. We're going to talk about interferon gamma later, interleukins, cytokines, chemokines, and complement system. And then the innate immune response in terms of, we also have the adaptive immune response that captures antigens from the pathogens and then presents itself to T lymphocytes, which then brings us into the adaptive immune response. So again, slower but targets with specificity. T and B cells are the two primary cell types that are involved, and then some again change into memory cells. So this is just a picture, another schematic, a form of looking at it. We have the antigen presenting cells here with adaptive immunity that combine with the MHC, which allows it to be presented and understood with a T lymphocyte in terms of class of identifying. So inflammation, we do need inflammation. Inflammation is a good thing. The challenge is when the inflammation is too significant or the chronicity of it. So these are just a basic piece on inflammatory markers. So we have IL-1, IL-6, TNF alpha, and then the pro-inflammatory pathway, which is triggered, NF-kappa B, which promotes cytokine production and recruitment of inflammatory cells. And then if inflammation does not resolve, so the cytokines get brought to the site of infection, and if it does not resolve, it starts this vicious cycle of inflammation, and then it turns into a chronic inflammatory process. So the biggest issue is the chronicity of it. And sorry, it's cutting off this piece. I'm doing it through the Google Slides, and for some reason it came out a little bit different than the download version. So I will make sure to read that though on the bottom for you guys if anything gets cut off. So why T cell testing? So why T cell testing? So three main reasons is it's going to allow for diagnosing of chronic infections as well as autoimmune diseases. So we have these antigen-specific T cell testing that helps to accurately diagnose difficult infections and autoimmune disease. So it's going to allow us basically to distinguishly monitor T cell responses that correlate with the stage of disease. It also allows for monitoring disease progression and treatment effectiveness. So we look at the T cell counts, particularly CD4. We're going to go through the reports of CD4 and CD8 cells, which are going to be vital for monitoring immune health and treatment efficacy in diseases, especially chronic diseases like HIV. And then changes in T cell subsets can indicate disease progression or response to therapies as well. It also allows for personalized medicine. So we have the T cell testing and monitoring that can actually identify specific T cell signatures that are linked to disease outcomes, which allow for personalized treatment strategies and tailored immunotherapies by getting a lot more information. So again, looking back on the adaptive immune system, we have the T cells and the B cells, and then again, much more specific than when we're looking at the innate immune system. It targets specific antigens found on pathogens via the lymph nodes. And the dendritic cells and macrophages present pathogen fragments to T cells to then trigger the response. And then in terms of the immunological memory response, we have the memory B and T cells, which persist long-term to quickly react to future infections. The antigen-specific T helper cells, we have many, Th1, Th2, Th17, often discussed to help fight pathogens. And T cells basically are the first line of defense, includes helper T cell CD4 that help to coordinate And then we also have the cytotoxic T cells that directly kill infected or cancerous cells. So when we're looking at the T cell response, the assay with the ELISpot, it basically measures the T cell response that is active during the infection process. And the T helper cells are the primary mediators of immunity. So the major effector cytokine, when we're looking at the T helper, the Th1, is interferon gamma. So IFN gamma, again, we're going to show that later in the actual case examples. And what it does is it can detect acute infection and low infectious burden. So IFN1 gamma, and then extremely useful for disease that displays a Th1 skewing and also can have a weak or absent humoral B cell response, such as Lyme and COVID. So you'll see, like for example, for our office and one of my areas of specialty, Lyme disease and tick-borne infections, they might not have enough of the antigen, the antibodies present, even though somebody might have a chronic long-term issues with Lyme disease. And so the Th1 is very useful in showing activity, and especially for infections like Lyme and COVID. And it's also useful for immunocompromised with low immunoglobulin levels, and then also T cells must be kept alive. Spotlight. Okay, just make sure nothing happened in the video. So T cell function overall is crucial for proper immune defense. It develops in the thymus, and we recognize antigens only when it's presented by the major histocompatibility complex molecules on the surface of other cells. So we have this MHC, these peptides with the antigen presenting cells that allow them to have these unique receptors to identify these T cells. So they come in various subtypes with distinct roles. We have four main types. We have the helper T cells, we have the cytotoxic T cells, regulatory T cells, and we have the memory T cells. So the helper T cells, CD4, helps to coordinate an immune response by activating other immune cells and fighting in the tissue itself. And then cytotoxic T cells, CD8, they kill infected or abnormal cells. We have the regulatory T cells, which are like the peacemakers. They help to suppress immune response to maintain self-tolerance. And then we have the memory T cells, which provide long-term immunity after infection or a vaccination. Let me just see if I can, sorry, one second. I'm going to try to see if I could make this a little bit smaller. Okay, one second. I'm just going to read off the bottom because I want to make sure we're not missing anything on the slide content that I give to you guys. Okay, so the Th1 cells are known for, again, being active and in acute infections, and they produce interferon gamma, and Th1 cells primarily produce interferon gamma. So they're working through what's called a positive feedback loop, which is key to the immune responses for intracellular pathogens. And the issue is if it's not properly controlled and we have high levels and this continued positive feedback loop, that we're leading to potential autoimmune conditions. This again is how the T cell frequency and antibody titer. So we have, again, the T helper cells early on showing elevations in terms of for an acute infection, and then the later stages with recovery and resolution. So if you look, the pathogenic burden drives the immune response. So a high number of pathogens drives this T cell generation and the T cell development. So responses will change based on this pathogenic burden during infection. So these levels of disease will actually correlate with these functional signatures I mentioned, interferon gamma. We're going to also talk about IL-2, but we have this exposure, we have the acute infection, this elevation, and then again, later resolution. And there's a shift of Th1 overall to central memory development. At the end, the immune system quiets down because the number of pathogens is low. So less T cells are generated, pathogens that our immune system cannot then clear, and then you go into more of a latent phase, which is basically it's not actively replicating and is dormant at that time. So we're looking, when we're looking at the T cell testing, is the higher burden of active infection to see how much of how active that infection is. So so when we look at checkpoint one, where we have the antigen-specific Th1 T cells. So I mentioned interferon gamma, that you're going to see a higher amount of that. And then antigen-specific central memory T cells, you'll see less activity. So this is what it is actually looking at and capturing. And then when you're going in further phases, there's a lower pathogenic burden. As you see, this is an acute infection. This is like in the middle point, checkpoint two, where you start seeing from having no antigen specific sensory memory T cells for IL-2 to now having some present. And then you see here, which is later in the phase of resolution, checkpoint three, we have the clearance of infection. You'll see the interferon gamma having no activity, and then you're going to see higher levels of IL-2 central memory T cells that are now showing as active, showing that the infection is cleared. So antigen-specific T cell testing will actually measure how many T cells respond to an antigen mix, and changes in antigen-specific T cell measured indicate disease and progression of treatment. So as I said, the checkpoint 1, 2, and 3. We're also going to be looking at, which we'll go through the case studies, the immune assessment, IAI, which is, are the T cells in fighting mode or not? What are the actual percent of responders, and then actually how well are they fighting? So not only just having that elevation of like CD4 and CD8, but what it is the IAI index, and are they actually equipped to be able to fight the infection well? And if low, which we'll discuss, we're going to look at that somebody has an immune dysregulation or immune, there's an issue with a chronic immune burden, basically. So how well are they fighting? Is it exhausted immune exhaustion, dysregulation, which we're going to get from the immune assessment? And is the immune system suppressed, which you're going to get that from that, as well as checking for the T helper cells. Then we're also going to have the immune senescence, which we're going to discuss at the end, which is an indirect measure of the aging process of the immune system. And senescence often correlates with less diverse T cell receptor repertoire and non-functional senescent cells, such as zombie cells. So with the functional T cell test, we can assess the immune status. So we first quantify how many T cells are in fighting mode, the percentage. We also quantify the cytokine production per T cell. So that's that immune assessment index I mentioned earlier. So how much cytokines do we actually have per T cell to show how well the T cells are fighting? Then we're going to look at the active CD4 and CD8 T cells for cytokine production. And also we will look at the percent active CD4 and CD8 cells. And then the, again, immune assessment index represents how many cytokines per T cell during stimulation. So you can see it here on the schematic. You have the unstimulated, and then you have the stimulated, where you're seeing a greater amount of activity in terms of response to infection. So in an ideal state of no infection, a resting immune system, this is going to be how the report presents itself. So you'll see these are negative here, and then you're going to see the CD4 and CD8 are low because there's no active infection. So no infection, you'll see the markers all on the left side of the reference interval. And then you'll also see a low percentage of TCD4 and CD8, which again are active during more stimulation. So you're going to see low activity because there's no infection. And then there's also a low amount of cytokines per responding T cell. The immune assessment, which you can see here, IAI, let me just make that bigger, immune assessment index, is also low in terms of the number of cytokines, again, per T cell. Now, this is a case where CMV looks to be reactivated, and you can see the immune system is fighting. So you'll see here the CD4 and CD8 are elevated along with the IAI. So the body is actively mounting a response. There's a high percentage of CD4 and CD8 during stimulation. You have a high amount of cytokines per responding T cell. And you can see here the interferon gamma, the number is supposed to be below 2. You see the number at 295. So this really shows a likely acute active infection, and the body is doing, properly what it's supposed to do by having a higher amount of stimulation of CD4 and CD8 as well as the IAI. Now, this case is likely more of like an autoimmune patient when you're looking at this case overall. There's active CD4 and CD8 cells, but then what you'll see here is the IAI, the immune assessment index, is lower. So that is showing there's a lower amount of cytokines per responding T cell. So in this here, you see also interleukin 1 beta is elevated, interleukin 8, which are typically elevated when you're looking at autoimmune conditions. We also see CD4 and CD8 that are active during stimulation. So it's showing there's hyperactive immune response. So even though there is a hyperactive immune response with the CD4 and CD8 being elevated, as well as interleukin 1 beta and IL-8, we see that the body is not necessarily responding with properly by having enough cytokines per responding T cell. So the best way, we're going to go into this a little bit more to explain it, is we have the CD4 and CD8, then we have the immune assessment, and you have like soldiers. So you have enough soldiers with the CD4 and CD8, but you don't have enough ammunition with the IAI not being high enough to actually properly mount a good response for the body. So this one here is the EBV reactivation. And with EB reactivation, this is an example of someone that is potentially like exhausted in terms of immune function being exhausted. So we see again the threshold, anything above 2 is considered positive, and at this person it is at 66. And then here, when you look at the lytic interferon gamma, again, both of these highly elevated. You see that these are negative though for IL-2. So what this is showing is that there is likely EBV reactivation. The interesting thing here is that you'll see that the CD4 and the CD4 and the CD8 here are a little, CD8 specifically, are a little on the lower side. So what this can indicate is that the immune system is exhausted by not producing enough of the proper, in terms of the T cells, they're not going up high enough to be able to mount a response. And so that's typically indicative of more exhaustion, but it is showing here that there is elevated, there is EBV reactivation, and it looks like based on this that it is more recent. This is another case review of a patient, 83-year-old patient that has EBV reactivation. And you can see here, again, interferon gamma is positive. But in this case, unlike the other one, you see the other ones, the numbers were like 66 and we had like 295. This number is lower, so it could possibly indicate, and this is where getting the history from the patient could indicate that it's been longer in terms of a longer time for infection versus more recent and active. And you also want to look at other infections. You can see as it pertains to the CD4, the number is a little bit on the lower side. The IAI is okay, but the CD4 response and the CD8, I think the CD8, yeah, the CD4 is definitely low. So you're showing that the body is not necessarily mounting the proper response. So showing some type of likely as well immune dysregulation when we're looking at this report. Now we look at this one. This is for long haul COVID patient with residual SARS-CoV-2 response. So in this one, we have a low antigenic burden to SARS-CoV-2. We have a high percentage of CD4 and CD8. So the responders, so it's showing there's a hyperactive or pro-inflammatory state, but we're showing again a low IAI. So the body is not properly responding to the infection, even though the CD4 and CD8 is elevated. We also are seeing that in this case, this is likely a person potentially that has long COVID. Now, why? I discussed earlier that interferon gamma, that the IFNY is going to be more, that's going to show more with an acute active infection. And we're going to see higher levels of things like IL-2 when we're going later on into the stage. So we're looking at the memory cells that I talked about. So this number is elevated, and this number is, is basically equivocal. So this is where it would be good. But the interesting thing in this situation, though, the CD4 is still elevated, showing that the person is still actively, the body is actively fighting an infection because those numbers are elevated. So it is indicative of someone with long COVID. But what you want to do is ask the patient, in this case, like if they remember having COVID, what was the time frame? Was it like 3 months? Was it a year? If someone says it's been a year, that would be much more indicative of long COVID situation. The other thing is, since the CD4 is elevated, you want to make sure that they don't have other infections. So this is where you want to check for things like EBV or cytomegalovirus or things like Lyme disease, because of the fact that these are high, indicating that there is activity, that there might be some other acute infection going on as well. So this is where history taking with the information is going to be really important. But this is showing this is likely to be a potential long haul COVID based on the way this report is showing. So if we look here, I just want to make sure. Okay, so this one is also showing PD1 and PD2. So these will be, we're going to go into that more later. This is programmed cell death. And so when those are really high, that's showing an indication of like hyperactivity, immune response. And for this person, it is actually lower. So, but they have a high percentage of CD4 and CD8. So when we look at T cell immune exhaustion, there's a dysfunctional state of T cells occurs during chronic infections or cancer. So it's characterized by progressive loss of effector functions. So cytokine production as well as cytotoxicity. So the T cells remain alive, but they fail basically to control the pathogens or the tumors effectively. So what you'll see is impaired IL-2, you'll see impaired interferon gamma and TNF alpha production. You'll see poor cytotoxic killing. You'll see reduced proliferation that causes dysregulation. And then you'll also see sustained expression of inhibitory receptors. So this is driven by viral infections, COVID, autoimmune conditions, mold can also cause it, tick-borne infections like Lyme disease, Bartonella, Babesia, and or other co-infections like EBV. So what we will also see in the reports, which we're going to show an example next, is what's something called PD1, which is programmed cell death protein 1. So this is basically an immune checkpoint receptor that is expressed on T cells after activation, and it normally functions to prevent overactivation and autoimmunity. And so in chronic settings, you'll see high PD1 expression, which then represents dysfunctional or exhausted T cells. And this correlates with poor immune response, particularly in chronic infections and cancers, where you see higher expression of what's called PD1. PD1 also binds to PDL1, PDL2, and other cells, that transmits inhibitory signals that blunt the T cell function. So basically, it's considered like an off switch for the immune system. So the easiest way to think of it is like a brake, and then you have PDL1, which is actually the foot that's pressing the brake. And so the PDL1, which is the foot, is touching PD1, which is the brake, and it's telling the T cell to actually stop. So it's saying, don't attack the cell; it's part of the body. And it's basically preventing your immune system from attacking your own tissues. And if you have high PD1 expression over time, that's going to be shown in chronic infections, where you're going to have this dysfunctional and exhausted T cells over time from this elevation of this PD1, high PD1 expression over time. And if you look at a cancer, which we have here, PD-1 expression activation, PD-L1 or PD-L2 inhibits T cells from activating. So it's most looked at with cancer. And in this situation, it basically, the easiest way to describe it wears its disguise by producing lots of PD-L1 on the surfaces. And so it causes basically a false signal to the T cell where it's saying, stop, I'm a normal cell, don't attack, but it should be attacking it because you're having a lot of production of this PDL1, which is causing basically it's causing a false signal. And you have this impaired immune clearance, you have impaired cancer and ability to fight the infection as a result because of this PD-1 expression. So we have a unique and functional test which can assess immune exhaustion by quantifying this PD-1 expression on T cells. So we're looking at how many CD4 and CD8 cells are expressed on PD-1, how much PD-1 is expressed per T cell. And what you're going to look here is at the MFI, which is immune fluorescent intensity. And what we're looking at here is how many PD-1 molecules are expressed per cell. So how many cytokines are made per PD-1, CD4, and CD8 T cells. And note again that the higher the MFI, the higher amount of PD-1 molecules that are expressed per cell, the more expression on the cell surface. Here we have Aspergillus infection, which is with a mold case with potential immune exhaustion. You see Aspergillus is positive. They have a high percentage of CD4 and CD8 active cells. They have a relative low immune assessment index, showing that there's, again, not enough like tank in the gas to actually mount a proper response. So there's some dysregulation, immune dysregulation. And then you have a high percentage here of C4, CD8, as well as PD-1. So again, showing that there's immune exhaustion. So you could see here the PD-1 here on this first row, and the CD8 as well being elevated. And this is a case for EBV reactivation with potential immune exhaustion. So we have the number where we're showing, again, reactivation of EBV. The number is 296 when we have a scale of it needing to be greater than 4 to be positive. And we also have, in this case, SARS-CoV-2 interferon gamma also being elevated. So this could be a case, the interleukin 8 is also elevated in tumor necrosis factor alpha, which we know TNF alpha, IL-1 beta are two other markers, cytokine markers that will go up with an acute and active infection. So it is looking like, in this case, potential COVID plus reactivation of EBV, and then also some immune exhaustion based on the response here when we're looking at the next, because the CD4 is lower, so not producing accurate amount of CD4 for an active infection. And then this is the next one. So I wanted to go through quickly, and then we're gonna leave it open for questions. I wanted to go through quickly the other lab, immune senescence lab, that iLabs has as well, to look at our increased, the body's response to infections. And so when we look at immune senescence, a lot of times people refer to what's called inflammaging, but there's many different parts as we're looking at immune senescence overall. So we have inflammaging, which is the inflammatory mediators. You'll see elevations of IL-6, CRP, and then also increased T cell or tissue dysfunction rather. T lymphocytes, you'll have an increase in memory T cells, but what you'll see is there's lower diversity of T cells. So the T cell diversity is lower. B lymphocytes, you'll have lower naive B cell pool, higher memory B cells, lower IgM, but then higher IgG. You also see in terms of IL-7 production is down, and also thymic output is down. And the overall changes you'll also see is decrease in telomerase activity, which is a function for like anti-aging that they look at, increase in tumor incidence, increase in tumor or infection rather susceptibility, There's also an increase in inflammatory reactions, and then also, because of all this, a decreased response to vaccinations as well, and decreased response to be able to fight infections overall as well. So how we test for immune senescence. So these are the functions that we're looking at: immune cell profiling. We're looking at CD8, CD57, and granzyme B and T cells. We're looking at telomere length testing, which is the relative length qPCR of immune cells. We're looking at the T cell receptor excision circles, which measures the thymic output, which is the production of naive T cells. We're also looking at the inflammatory markers: IL-6, TNF alpha, CRP, IL-1 beta, MCP1. CMV is another one because CMV is known as a driver for PP65 and a marker that we're looking at for immune senescence, and then also functional immune assays and immune assessment. So if we look here, we have the CD8, CD56, granzyme B cells accumulate in age and enhance immune senescence. So the more that we're having of those, it's kind of like I mentioned before, zombie cells. When we have this accumulation of zombie cells, they're not really doing anything. I guess the easiest way to, just like it sounds, zombie cells, or if you had trash and the trash person didn't come and pick up the garbage, the trash is accumulating and you have that quote unquote garbage in your system because it's not active and it's there with no real benefit or function. So what you'll see is higher amounts of CD8, CD56, and granzyme B cells accumulate, these like zombie cells, which enhance immune senescence as well. And so that's one of the markers checked in that test. So it includes, again, a combination of testing. So we have the flow cytometry, the T cell subset analysis of the CD8, CD57, we have granzyme B, and then we have T cells. We have telomere length, the biological aging of immune cells through qPCR testing. We have the inflammatory cytokine panel, which I mentioned, like CRP, IL-1 beta, some of the initial markers for that acute inflammatory response, and also in high amount showing chronicity of inflammation. And then we also have the CMV reactivation status that's also being tested, T cells and IgG, which assesses chronic antigen stimulation. Okay, and then so now before we go into Q&A, iLabs is also accepting. So for you guys, this is the QR code here to be able to look at using, to be able to use this lab. But one of the good things to know, it's now approved by Medicare Part B for medically necessary diagnostic lab testing. So please look at that QR code as well, which is a great thing for your patients that are under Medicare. Okay, so thank you everybody for the presentation. So if you are interested in learning more, this is the website here and the phone number. But what I'm going to do now is actually allow Felix Schultz, who is with iLabs, to share his screen as well before we go into Q&A.
Yeah, hi, Jaquel. Thank you very much for the awesome presentation. Yeah, was well done. And I actually have right away questions for you. So it sounds like you see quite a few long haul patients, and I'm curious, what do you think is for you as a healthcare provider the biggest challenge if somebody where you suspect long haul COVID in a patient to work with that patient?
For us, I think what happens is a lot of the people that we see often tend to have other infections, and that's what we kind of went through with that case, or I discussed with the case with the CD4 and CD8 being elevated, and the getting that clinical case to find out the time frame of like when they believe they had COVID, because some people, as we know, think they may or may not have had it, so they're not really sure like what's the role it plays with everything else going on. So I think the part that is tricky for us at least is also ruling out other infections. Like, was EBV reactivated? Do they have Lyme disease? Because a lot of the people we see have like Lyme disease and other tick-borne infections. Do they have, I'll see sometimes like autoimmune conditions, that the autoimmune conditions, some of those antibodies will also get elevated. Is it elevated because they just got COVID, and what's the role to play with that? So I think what's good with this, at the T cell testing, we're just getting a lot more information of what role that has to play given with everything else. So I think it makes it from the diagnostic standpoint a lot more clear as a clinician. If you're thinking of somebody having, of course, my dog's gonna bark at the neighbor. If you're thinking someone is having long COVID, it's giving a lot more diagnostic information. But I think the tricky part is you also have to look at all those other infections that they have, the other inflammatory markers, which we have some of them from this lab, and then look at it in the totality with the case study to decide, because that's always the one, is like which one is playing a greater role than the other. And so what I'm often looking at is like the number and the count in relation to the other ones that I'm testing for.
Mhm. And another question, so for me, I'm a scientist, so I have no clue about how to treat people and take care of them. So what are then your options in the different? I understand that long haul COVID is really complicated, right? So what are different scenarios that you frequently encounter, and what are your options like in treatment? What you use?
Yeah, so for us, well, and I'm a naturopathic doctor, so we're doing more integrative medicine with what we're recommending. So, but I do look at, like I mentioned, outside of other infections, other markers. So sometimes I'll see with patients, they become like very nutrient deprived, like vitamin D, vitamin A becomes depleted. A lot of these ones that are for immune function. I'll see like iron, because ferritin is also a marker for like acute inflammation. I'll see like ferritin will tank and their iron is low. And so if those are low, as we know, iron shows symptoms of brain fog and circulation issues and heart issues and things like that. So the first thing I'm looking at is typically like nutrient status, to make sure that that is like repleted in terms of like zinc, vitamin A, vitamin D. And then I'm looking at other nutrients to help combat like viruses. So some of the things we use as NDs are like NAC, glutathione. Glutathione helps with, for example, the half-life in terms of preventing, like decreasing that cycle in terms of the replication, making that shorter. And also things like if they're having symptoms, this is where we're going to look at everything, like where they're having, let's say, respiratory issues. That's where I'm going to be looking at like NAC and vitamin D, because those are really, really helpful for respiratory function. I might be looking at things like quercetin. Quercetin was studied when we look at like long COVID. That was one of the ones that was studied, as well as like zinc. So I'm typically looking at more like nutrient support for when it comes to COVID. But I will do antimicrobials as well, and that kind of depends on what infection they have, that of what microbial I'll use. From the medication standpoint, we might look at things like obviously some like IV therapy. We might look at also mitochondria is really important to support that. So like CoQ10, B complexes, because any infection is going to deplete the mitochondria, and and that's why one of the symptoms commonly is fatigue. I know some people, if there's like autoimmunity or a lot of inflammation, things like low dose naltrexone is something that's used. So those are some of the ones that I'll look to kind of partner with our team on what makes sense. IVIG sometimes for some people if they qualify as well. And then obviously antibiotics too.
Okay, awesome. That sounds, yeah, complicated.
I said a lot. Yeah, I said a lot. Okay, and I'm seeing
Great.
I'm seeing some questions in here. Oh, also too, Felix, did you want to add anything that I didn't mention? Because you're, the scientist, so you're more technical. So are there anything that you feel like should be that wasn't, maybe should be enhanced by way of discussion?
Um, Yeah, no, I think your talk was really smooth and very good. I see here's a question about what we measure. So I think we have to explain that we measure two different assays. We have two different tests. One is the antigen-specific T cell test. We have that for, I think, 19 different diseases. And uh, what we use there, we use specific antigens. I think Jaquel mentioned that antigens are surface proteins more often of pathogens, and they end up in the lymph node. And T cells that recognize it develop into subsequent uh, specific T cells, and those are we able to measure in our ELI spotline. And the beauty of that is that the more action in the lymph node is, meaning the more pathogen, the more antigen, the more T cells are in the output. That's why we see in the antigen-specific T cell testing like a higher value. She showed a patient with like 290 something antigen-specific Th1 T cells against the latent Epstein-Barr, for example. That correlates with a very high Epstein-Barr viral burden, while opposed to the long haulers or suspected long haulers, where we saw like 5 antigen-specific T cells or in 115. So that is represents a low burden, and likely like the virus is in a viral reservoir. Like in the lamina propria is published that a third of long haulers have still remnants of COVID in the lamina propria or in the CNS. So that is what we measure in that. And the other test, the immune assessment, is where we use basically an immunological trick. So those T cells we stimulating specifically as T cells, but bypassing the T cell receptor. So we can run the test on any given patient. Like in an antigen-specific T cell setting, you need to know what disease probably is present because you use specific antigens for stimulation. So for the immune assessment, we just stimulate with T cell activators that bypass the T cell receptor. And basically, with that, we ask the question, how many % of recent made T cells are active? So, and that works because if you don't have infection, you don't have many active T cells because there's no need for them. If you have now active infection or reactivation, which she showed, we find a high percentage of T cells in fighting mode, what we call that. And that is the percentage, when we talk about CD4 percentages and CD8 percentages in the reports. So that is basically disease status agnostic test. You can run that on any patient under the sun. And if you see an active immune system in there, it's reason to look for what's actually going on, right? So we have to distinguish these two different types of lab tests. They're significantly different. So and in that case, I think I remember the patient that she showed that was, I think, one of the suspected long haulers with very low antigenic burden, but we still saw elevated active CD4 T cells. And I think Jaquel mentioned in that scenario, you need to look for maybe reactivations of Epstein-Barr or something. So that is the helpfulness of the immune assessment, that, okay, one disease may be on the way out or it's not present, but if you see immune activation, look for another infection, right? I hope that helped.
Okay, I was trying to see if there's any in the Q&A too. I don't see any Q&A. I'm just seeing if there's any in there outside of the comment section, Felix.
Yeah, I think I don't see any more. So please, if anybody has questions, I mean, we also can, if anybody wants to ask and unmute themselves and ask a question, I think that is fine too. So wait a second here. So you're measuring COVID-specific Th1 T cells. Yeah, antigen-specific Th1 T cells, that's correct. That's interferon gamma. And then we also measure the central memory T cells with the IL-2. And then it's a separate test exactly that measures CD4 and CD8 responses in a not specific way, which is just basically a supportive test that you can run on people to just check in. Hey, immune system, what are you thinking? And then the immune system will tell you, oh, everything is cool, I'm chill. Or it says, hey, I'm fighting. Or it says in certain scenarios, I want to fight, but I cannot fight when you have immune dysregulation. No, we don't measure PCR and spike protein directly. We measure in our stimulation mix is spike protein. So we measure immune responses against spike protein. And that way you can know also if there's an immune response against spike protein. That's the only way to know it, actually. Okay. Any more questions? Oh, okay. Yes. So our ELISpot line all looks at these two subsets of T cells, the Th1 T cell and the central memory T cell. And that is an antigen-specific manner. The reason why we do that is for a proper immune response and a proper infection, you should be fine with only looking at Th1 T cells because there's always a Th1 immune response in any given infection under the sun. So we look also at the central memory T cell for more intricate chronic diseases because the immune system senses if there's a lot of pathogenic burden or it's not. If there's a lot, no question asked, you find Th1 T cells. If you have a low pathogenic burden, like for example in Lyme disease or in long haul COVID, right? The immune system gets so few antigen that it thinks, oh, everything is cool, but I still have this little bit of antigen, so maybe I make a little memory T cell here. And then you catch that as well. If you wouldn't be looking at Th1, you wouldn't see it. So that's the actual reason why we look for these central memory T cells, because they indicate in case there's not a robust Th1 response in an infection, chronic infection, we can catch it with a central memory T cell response.
So the next question was, can you speak to collection and blood transport specifics a bit?
Okay. Yeah, it's a blood draw. We're looking at living cells. So we need to ensure a short time of transport. So everything is overnight. So usually I calculated it's between, depending on when you draw your blood. So it arrives every morning at, I don't know, 9 a.m. roughly in our lab. No ice. T cells like room temperature. If you cool it, you will get wonky responses. We did like quality studies on that, and it showed like even exposing T cells for like an hour or whatever in the fridge, yeah, makes the T cells do unreliable things. So room temperature is key, and we are just 20 minutes from the airport and the first stop in our facility, so we don't have any issues with shipment because it stays at room temperature, the whole shipment.
And then she said, because I was about to say clinically, we've sent it out by Wednesday, like Monday through Wednesday, but Carolyn put, yeah, Monday through Thursday, no
Monday
special
through
tax,
Thursday.
and FedEx prepaid envelope is also in the kits. That's
Correct.
awesome.
Everything you need is in the kit, so it's headache free. You just draw the blood, order the lab tests you like, pack it, have it picked up by FedEx. It arrives the next morning on our doorstep, and we run prepare the cells right away. So because we don't have time to waste on these, because the longer the shipment, the worse the outcome.
Carolyn might be able to answer this because they're asking, this is a good question for people that are remote.
Mhm.
I don't see why not. I think that should be the same as, because we use the mobile phlebotomist too, that we arrange for folks. So yeah, I don't see why you guys wouldn't be able to do that for
Yeah,
remote.
and any lab test now works with us usually. Like I know at least for certain places in California, we have customers that use any lab test now, so that works.
And then that's the other thing is the tubes don't have to be spun either, which also makes it easier.
No, again, like T cells are nifty things, so they need a lot of love. So just draw the blood, nothing to worry about. Pack them, ship them, and we take care of the rest. Okay. Good. So,
Okay. So
Jaquel,
I'll put this slide back, Felix, of the where to connect. Sorry, one second. If they have in terms of the website and everything, so I'm just gonna post that up real quickly before we end the call.
yeah.
Um,
Yeah, anyway, I really want to thank you for this. That was really nice and awesome. I really appreciate it, and specifically that you took the time out of your day with all that is happening in your life currently. I really appreciate that. Thank you
yeah,
so much.
nothing crazy happened here in the background, so.
Good. Yeah, in
So
my
I have
case,
a
neither.
3-week old. So, so thank you everyone for being here. This is the number to contact. I have been benefited from just personally being able to use it, especially for our patients that have different infections. I know, like Dr. Tusa had mentioned, like EBV, CMV. Sometimes I'll often do it with the conventional labs, and then compare these things up to get again a better picture of what's going on. So I think if you're dealing with a lot of patients, obviously suspecting of long COVID, but also infections and multiple infections, I think it allows you to get a lot more information of what the story is being told from it. So this is the website. This is the email to ask more questions. And I think that's it for us, right? And then everyone's going to get the recording after, right, Carolyn? So if they want to refer back as well.
Yes, we'll make sure to send it out. Thank you so much.
Yeah, thanks everybody for attending. Really appreciate that. Thank you.
Okay. Bye, everyone.
Have a great night, everybody.
Bye.